Welcome to another episode of the NEI Podcast. I'm Dr. Sabrina Siegel, and we are at NEI Max 2020. It's day 2, and we are here with Dr. Jeffrey Strawn for an extended Q&A session. Let's listen in as he addresses your most pressing questions from today's presentation on treating refractory anxiety disorders. So we are here with Dr. Jeffrey Strawn, and this is an extended Q&A. It will be a chance for Dr. Strawn to answer some unanswered questions that we didn't have time for after his excellent presentation on treatment refractory anxiety disorders at NEI Max 2020. Welcome, Dr. Strawn.
Thank you, Sabrina.
Our first question is a question that you received quite a bit. I think everybody is dying to know what your preferred SSRI is for treating anxiety.
So it's actually a great question. And certainly in terms of picking a medication for the treatment of anxiety disorders, whether we're talking about pediatric or adult anxiety disorders, the evidence really suggests that we're better choosing an SSRI relative to an SNRI. And that's both in terms of how quickly patients are likely to get better, as well as the amount of overall improvement that we can expect to see. Now, among the SSRIs, there's, as the listeners know, considerable variability in terms of primarily the tolerability of these medications. And therefore, I tend not to use medications like paroxetine that have a lot of antihistaminergic as well as anticholinergic side effects. Although at the same time, there was a period of time when, because of these sedating properties, they were actually marketed for the treatment of anxiety disorders. With regard to the SSRIs that I would prefer, certainly escitalopram or citalopram are the two medications that I would probably go to first among the SSRIs. Now, the main reason there is that obviously all of the SSRIs are going to block that serotonin transporter. But what's different in terms of escitalopram are two things. First, it's going to be among the most selective of the SSRIs with regard to serotonin relative to norepinephrine. Second, escitalopram is actually going to allosterically modulate the activity at that serotonin transporter. So what do I mean when I say that? Well, all the SSRIs are going to primarily bind to that active site at the serotonin transporter and block the reuptake machinery. But when escitalopram binds, it's going to bind to that active site, but it's also going to bind to an allosteric site on that receptor. And in doing so, what happens is that it actually increases its own binding to the active site and thereby enhances its reuptake efficiency, if you will.
That's so interesting. Thank you for sharing that with us. And another question that we received was, what were your thoughts on the SNRI dose-response relationship? You mentioned that it was complex.
Complex is a great word to probably describe this relationship. So just to orient everyone, we talked about the SSRIs where recent meta-analyses, both in pediatric patients as well as in adult patients, suggest that there are some dose-response relationships. They're probably a bit stronger in adults relative to kids, and there are a number of factors that probably subtend that. Now, with regard to the SNRIs, what we talked about in the presentation was that there's no relationship between the dose, or probably also indicating blood level or exposure, of the SNRI in response. Now, that doesn't necessarily mean that we don't get benefit from increasing the dose of the SNRI. What that probably relates to is the fact that there's a lot of complexity in terms of what we would call the target engagement at that norepinephrine transporter. And one of the things that we know, particularly with regard to some of the studies of venlafaxine, is that just like we have variation in that serotonin transporter, we have variation in the norepinephrine transporter. So to take a few steps back, with the serotonin transporter, one of the things that we know is that in individuals who have two short forms of the serotonin transporter promoter polymorphism, so in other words, they have lower expression of the serotonin transporter, they're going to tend to respond at lower doses of the SSRI. That's compared to individuals who are heterozygous for the long form or homozygous for the long form, who have much more expression of those serotonin transporters. In essence, we can think about the presynaptic terminal being painted with serotonin transporters in those individuals. Now, with regard to the norepinephrine transporter, we actually have three forms. We have a T form, a CT form, and a CC form, or homozygous C. Now, what we find is that individuals who are homozygous for the T form or have the CT form of that transporter, they tend to take a lot longer to actually get to remission when they're treated with venlafaxine, relative to those patients who are homozygous for the C form. Now, those individuals are actually going to have faster improvement in general with venlafaxine. The other issue is that the relationship between dose and response is probably also affected by tolerability. And particularly in the case of something like venlafaxine, where we have tremendous variability in terms of whether we're getting an SNRI or predominantly even an NRI in individuals who, for example, are ultra-rapid metabolizers of 2D6, we have tremendous variability. And again, if we think about, given what we know about the SSRIs, that we generally have more efficacy with the serotonergically focused interventions. In some of these patients treated with venlafaxine, we may not be getting much, if any, serotonergic activity or serotonergic blockade of that serotonin transporter. So again, I think taken together, this variability really significantly influences, in many ways obscures that ability to detect a dose-response relationship. So for a given clinician, I don't think that there would be anything wrong with increasing the dose of an SNRI in a patient who, for example, had a partial response.
Yeah, it definitely is complex. Our next question is, how would you deal with discontinuation syndrome for SSRIs?
That's another really good question. So how we deal with the discontinuation syndrome really requires us to talk about how we discontinue the medications. And so taking a couple steps back here and thinking about how we discontinue the medications, more recent data actually suggest a hyperbolic discontinuation as being certainly better from a tolerability standpoint, but maybe also better in terms of lowering the likelihood of relapse upon discontinuation. Now, we have relatively few of these discontinuation studies in psychiatry. Really, with regard to the anxiety disorders, we only have 3 or so that I can think of in terms of the SSRIs. Now, what do I mean when I say hyperbolic discontinuation? In general, what we would want to think of if we're looking at a patient, say, for example, who's treated with escitalopram 20 milligrams, is reducing the dose by half, approximately every 4 weeks. So at that first decrease, we would go from 20 milligrams to 10 milligrams. Then perhaps another 4 weeks later, we would decrease from 10 milligrams to 5 milligrams. Now, many would have previously stopped at 10 milligrams, given that is the FDA recommended starting dose. But what the hyperbolic discontinuation compels us to do is to decrease the dose further from 5 milligrams to 2.5 milligrams over that next month or so. Now, again, those withdrawal symptoms can look like withdrawal emergent anxiety, jitteriness. They can include autonomic symptoms. They can include things like headaches, palpitations, shortness of breath, really a myriad of symptoms that have been pretty well described over the last several decades in patients discontinuing these medications.
Mm-hmm. So fascinating. The next question that we have is, could you comment on sympathetic hyperactivity and use of blood pressure medications like propranolol for anxiety?
Yeah, so this question actually touches on something really important, which is that many of these patients will actually have fairly pronounced autonomic symptoms associated with their anxiety. And we really need look no further than most of our symptom inventories, and even in some cases, the DSM criteria to appreciate that. What we find is that in many of these patients, there is at least some evidence of autonomic hyperactivity that primarily comes from studies that have looked at things like salivary alpha amylase, although there are some older studies that use other proxies of sympathetic as well as parasympathetic tone, things like heart rate variability, etc. Now, with regard to the I'm going to say anti-adrenergic medications as opposed to antihypertensives, because I think that probably captures more specificity in terms of what we're focusing on. For propranolol, I think it can be helpful in some situations where individuals do have pretty pronounced cardiovascular or autonomic symptoms, as well as just generally dampening that hyperarousal that may accompany many of these anxiety disorders. And clonidine for me has not necessarily been the go-to. And that's really for two reasons. One of which is that it's a pretty dirty drug, and I think in terms of the side effects, at least with regard to peripheral side effects, it tends to have a lot of orthostatic hypotension. It also is something that has such a short half-life and therefore probably in many cases needs to be dosed TID or QID if we're actually looking at the pharmacokinetic data. With regard to staying with the alpha 2 agonists like clonidine, it is probably noteworthy that there is one pediatric study that looked at the alpha 2A agonist, guanfacine, and it specifically looked at an extended release form of guanfacine. What was noted in that study is that there were some improvements that emerged relatively quickly and that were sustained. And I think that's probably also worth underscoring given that this is a study that actually wasn't powered to detect that. But what's important in terms of the difference between clonidine and guanfacine is that while they're both alpha 2 agonists, clonidine is going to affect alpha 2A, 2B, and 2C receptors, whereas guanfacine is primarily going to be specific for that alpha 2A receptor. And I think that's something that's relevant in terms of some of those side effects that I mentioned just a moment or two ago. So we see that there are a number of alpha 2B and C receptors, primarily throughout the splanchnic and renal vasculature, as well as throughout the general peripheral vasculature. And that's probably what gives rise to a lot of the hemodynamic adverse effects associated with clonidine that really aren't as pronounced with guanfacine. That being said, with guanfacine, we do need to worry about hemodynamic side effects. It is associated with some bradycardia and can be associated with some orthostatic hypotension.
The next question that we have is, does lamotrigine have any benefits in treatment-resistant anxiety?
This is a good question, and I think really where this question is relevant is in those patients who perhaps have another reason for being on lamotrigine. So, for example, a patient with bipolar disorder in whom we're using lamotrigine as the primary mood stabilizing agent. The studies with regard to lamotrigine and anxiety have actually been quite mixed, probably in many ways like the studies of lamotrigine for bipolar depression. It may certainly have some role in managing anxiety, although it probably is not something that really falls within the first 4 or 5 items in my go-to list of medications for treatment-resistant anxiety.
We had a number of questions about bipolar disorder with anxiety and how to manage that. What about treating anxiety disorder patients with bipolar disorder where antidepressants are problematic? Does valproic acid or lithium demonstrate anxiolytic effects? Do other antipsychotics work? What are your thoughts on that?
This is a really important question and probably one that we could spend an entire podcast discussing. Something that's probably important for us to remember is that anxiety disorders are the most prevalent co-occurring illnesses in patients with bipolar disorder. And in some cases, the estimated comorbidity may be as high as 30 or 40%. The other thing that's relevant for us to remember as clinicians is that when a patient with bipolar disorder has a co-occurring anxiety disorder, this co-occurrence is associated with a very different phenotype. So these are individuals who are going to have higher rates of disability. They're going to have more subsyndromal symptoms. They're going to have more suicidal behavior. They're going to have more depressive episodes. And interestingly, they're going to have an earlier onset of the bipolar disorder. Now, when we think about treating these patients with bipolar disorder and a co-occurring anxiety disorder, we have to be a little bit cautious in using our go-to SSRIs because we certainly know that from many prospective studies, when these patients are treated with SSRIs, it can be destabilizing. That being said, this is not necessarily to say that we shouldn't ever use an SSRI in a patient with bipolar disorder who is appropriately mood stabilized. Now, coming back to this idea of mood stabilizers, the question could be maybe rephrased in terms of, are there specific anti-manic or mood stabilizing medications that may have a little bit better efficacy with regard to controlling anxiety symptoms? And lithium is probably the one that comes to mind first. And what's interesting is that anxiety is actually a negative predictor of response to lithium in patients with bipolar disorder. So what we see is that those patients with an anxiety disorder and bipolar disorder who are treated with lithium tend to have poorer responses to lithium. Now, that contrasts with some of the other mood stabilizing medications like divalproex as well as carbamazepine, which may actually have some specific benefit for co-occurring anxiety. Now, it's probably also relevant to highlight that a lot of this comes from open label studies as well as analysis of secondary and tertiary data in larger randomized controlled trials. The bulk of the evidence, though, really is for the mixed dopamine serotonin receptor antagonists. And again, when we're using that for anxiety, I think it's important to underscore the fact that we're not needing those same doses that we might use for treatment of a manic episode or treatment of an acute psychotic episode. Because what we're really focusing on here in using these medications is the 5-HT2A effect, although there certainly could be some contribution from the D2 antagonism. But remember that blockade of the 5-HT2A receptor is actually happening in a much lower dose than the blockade of the D2 receptor.
Wow, well, this was so fascinating, and I'm so glad that we had another chance to get to address some of the questions from the audience today, because there were so many for your talk. So thank you so much, Dr. Strawn.
It was my pleasure, Sabrina, and you're right, those questions were fantastic.
Thanks for listening. Stay tuned for the next extended Q&A sessions from NEI Max 2020, and make sure to subscribe.